record button. So right now we are being recorded, and please stay muted. The Zoom instructions on the top right corner view. If you want a gallery view or speaker view, if you go to speaker view, you will see the speaker and the presentations. If you go to gallery view, you will see all the squares. So we will be taking chat questions. I would like for you guys to hold off on those questions until the presentations, because we have 3 doctors that will be speaking. And I'm going to go ahead and throw it to our president, Bill Westlake.
Hi, everybody. Name is Bill Westlake. I appreciate you giving us your Sunday evening. This is going to be an exciting show tonight. I call it a show. It's something I've been anticipating and looking forward to. And it's going to be great information, so listen up. I just typically, I make a few announcements on behalf of ALK-positive Incorporated. Just as an introduction, again, my name is Bill Westlake. I'm president of the board of directors of ALK-positive Inc. And we have 2 exciting announcements. Number 1, on Friday, we just hired our CEO. And this is a big move for our organization. We are a board of directors of patients and caregivers, and we really need to invest in the future of the organization. We need to make sure that we're doing the best in terms of strategy, the best in terms of advocacy, the best in terms of research. So we feel like this is an important move. We had a lot of candidates. We boiled it down to about 16 people. We hired a search firm to make sure that we did a really good job on this. And we boiled it down to 5 top candidates. And the last candidate, which is the one we gave the offer to, was unanimous among the search committee. His name is Scott Shell. We won't be introducing Scott this evening, but we will in a future ALKtALK. But just real quick, he's from Ohio. He's a PhD. He's an MD, and he has an MBA. So he has the rounded experience that we need to take our organization to the next level. He's a surgical oncologist, a medical director of the comprehensive breast cancer programs at the William Beaumont Hospitals in Michigan, former acting chief medical officer of basic organizations such as health-oriented and consulting firms. And he's a former board member of Johns Hopkins Hospital. So again, we are excited and thrilled to introduce him to you all in the near future. The other thing I wanted to mention, pretty exciting, is for those who don't know, we have an ALK Summit. It was an announcement that we recently made. It's an annual conference. It's called the ALK Summit 2022. It's in Colorado, Denver, Colorado this year. And real important, this is a kind of an everything ALK conference. Much like our ALKtALKs, we talk about everything under the sun with dealing with the ALK landscape. This conference brings together key opinion leaders, scientists, researchers, patients, caregivers, and we learn a lot. We have breakout sessions, and it's really important to meet our fellow ALK members. So it's going to be exciting. It's a hybrid event. So we basically, that means it's an in-person and virtual event so that everyone can participate. It's July 29th, 30th, and 31st. And this will be really 250 in-person event, will be about the max. So it's going to be first come, first serve. So it's real important that when we make the announcement through the Facebook support group or through a newsletter, that you sign up if you definitely want to be in person. I want to thank Nancy Pronsati. She's a board member, volunteer. She's done an amazing job planning this event and lining up the agenda with doctors and specialists and just pulling together a beautiful atmosphere for us to all join each other. And look for that announcement coming up this Friday, as to more details of the summit. So without further ado, thank you, Mark. Back to you. Thanks, everyone.
You're welcome, Bill. Thank you. Without Judith Tam, we wouldn't be here tonight. So I want to introduce Judith Tam for a few announcements and for her generosity. See if I can unmute Judith.
There you go.
There you go.
To say, I'm so impressed with the work that Dr. Marvin has shown with this research effort. It's really amazing. I think it's like she never sleeps. She got so much going so quickly from sources all over the world. And her research partners, Peggy Sue and Angel Chen, are much to be admired. I think we're really all really lucky to have them working on our behalf for our best good. And let me introduce Sophia Mariver. I have great admiration for her. She's a cancer researcher, specialist, and doctor, and oncology is her thing. And she's been doing this for many years, and she's amazingly brilliant. So here you go, Sophia.
Well, good evening, everyone, and thank you so much for joining us. It's an honor for me to be here with my team. And of course, I just want to share the screen to just show you the beginning of the presentation. Let's see, just want to get it. That did not work. Okay, right? Okay, let's just see again. Okay, let's try again.
Your screen did pop up, by the way.
It did pop up? Okay, yeah. Okay. Because, okay, now it's good, no?
Yeah,
okay.
You can make it bigger if you want.
All right. All right. Well, good evening, everyone. It's an honor to present to you. Actually, I'm not the only presenter. It's a team of us. And, of course, you already heard from Judy. Without her, we wouldn't be here. And we started assembling this team sometime around October, November. And I think we've come a long way. It is not long enough for any of us. We are very impatient, and we're working. Judy's right about that. We're working around the clock as hard as we can. Unfortunately, Dr. Gadgil, a much admired expert on ALK disease and non-small cell lung cancer and all kinds of lung cancer, and a dear colleague of ours. Unfortunately, he's fine, but he's not feeling too well, so he sends his regrets and commended us to all of you. So what you see here are our names, and what is important in the slide is Judy's picture, because she signifies the effort that she has put in to really just say, I want my legacy to be to improve the lives of many hundreds of thousands of people around the world. And there are not that many people one comes in contact in one's lifetime like Judy. And it is my my great honor and pleasure to know her as a friend and now as a benefactor as well. You see some pictures of cancer cells. We all are looking under the microscope every day of our lives in this group at cancer cells because we want to understand how they work. Here on the right, you see the cancer is typically denoted in blue, and here you see a blood vessel, and you see the cancer going into the blood vessel and sometimes going out of the blood vessel into places that it has nothing to do with where it started. Of course, we call those metastases. And you all know that, unfortunately, ALK-driven disease can metastasize early. So when Judy first posed this problem to me of potentially working on an initiative devoted to ALK, that was the first thing that came to my mind, because I have spent my whole career worrying exactly about this, about metastasis. And in particular, for the last about 6-7 years, I've been worrying a lot about how to predict and prevent brain metastasis, which is one of the most serious, if not the most serious metastatic event that a patient with any kind of cancer can undergo. And so that's why you see the picture of the NIH right here. in part because we just got a fairly nice grant to continue our work on brain metastasis. And wouldn't you know it, now that we are so focused on ALK, a lot of our work on brain metastasis will be on ALK. And so that's why I put NIH there. In addition to that, I'm wearing my Rogel Cancer Center shirt, and I would not be paying my dues to the institution that has nurtured my whole career, the University of Michigan and the Rogel Cancer Center, relatively recently named in the last few years. But we've been a comprehensive cancer center since the beginning of this era of comprehensive cancer centers. So what does that mean? It means that we have the obligation, in order to receive the NIH funding to be a comprehensive cancer center, to take all aspects of cancer prevention, cancer development, cancer treatment, cancer progression, okay, am I unmuted now? Yeah, okay. I was momentarily muted. I hope everybody can hear me. Mark, am I okay? Okay. So we have an obligation to look at all aspects of cancer development and to bring all that science to the patient. So this initiative is actually in that spirit, consisting of 3 projects. We have 3 different projects that are all related. These projects involve patients, they involve advisors. We have a notable advisory board with experts and advocates and patients, patients belonging to ALKpositive.org and other patients, Dr. Gadgil, Dr. Shaw, luminaries in the field are in our advisory board. And we have collaborators, and we like to expand the collaborators. But the important thing that I want to point out to all of you, which is a little different perhaps what you have heard before, is we are a single team. We are working as a team. We meet as a team. We discuss all aspects of the work. It's all interrelated. There is no separation. There is no turf. There is no territory. We are all in this together. So the 3 projects begin with patient material. Project 1 aims at arriving at a time where we can do precision drug evaluation or of multiple sources of patient material. It could be biopsies, it could be tissue resected in the operating room, it could be maybe circulating cells like those blue cells I just showed you going into circulation. It could be sites of metastasis, any other patient material. Project 2 that Dr. Sue heads up is a project to really understand molecular and cellular mechanisms of why ALK, non-small cell lung cancer, and ALK-driven disease arises to begin with. When does it arise? Which are the cells? She'll describe some aspects of that part of the project. The reason is, I feel, and that's why I came to talk to Dr. Sue when Judy first posed this challenge to me, I feel that we have not yet invented all the drugs we need to invent for ALK, not by a long shot. I think we are at the beginning of the journey to really understand all aspects of this disease. So a full front attack at the basic level is very important because it will suggest new strategies. And project 3 is new strategies right now. Can we synthesize new compounds right now, and can we take them to the clinic? And that's what Dr. Angel Chen will be the leader of bringing all of the science to the clinic, and she's prepared to do that. I don't know what happens, why I jump out of, sorry about that. Okay, so the first part, I want to talk about a few practical issues. When one deals with patient material, of course, one deals with patients who are very eager to understand how does this impact what may happen to me as a patient. Participation in research is the #1 reason we make progress in clinical medicine. I'm sure many of you, if not most of you, I would dare guess, have participated in clinical research. So I don't think I have to too much sell that topic to you. But one of the aspects that you may not be aware, or perhaps I just want to make sure I explain to you in great detail, is the regulatory approvals that are necessary to handle patient material and to handle the actual live cells from the patient, with the expectation of understanding what is the drug sensitivity of those particular cells. In other words, how do we eliminate the cancer cells, hopefully without affecting the normal cells? So that question is easy to talk about. It's very difficult to do in the laboratory. That's not difficult anymore for us. We can do it. We have demonstrated in the last 3 months, we have worked very hard to demonstrate that we can actually do it very consistently in the samples that we are obtaining from the operating room of lung cancer, and also with ALK-driven disease. But it was important for us because up until this time, we had done hundreds and hundreds of samples, but they were not necessarily very enriched for lung cancer. But now we have. So we are really working very hard to make sure we can collect all the samples, we can physically collect, and that we can test them and to be sure that all our methods in the laboratory are working for these samples. We have regulatory approval to do this at the University of Michigan, but not yet outside of the University of Michigan. However, as you know, this disease is not common, and unless we have a way to harness the great power of patients and doctors as broadly as possible, we are going to take longer to find answers. So it is very, very important to compare outcomes, to standardize processes, and to get to the point where we can have everywhere in the country a consortium of prospective protocols or an umbrella protocol. That is the goal. When that goal will happen is, I don't want to say for sure, but I think in the next year or so, we will be somewhere close to that. But we need to get to this point, and you see all the squares that are not checked. So we are systematically going to do all the checks, because unless we get to the point that we are what's called CLIA certified, we are not able to return results with the intention of driving treatment. And so I just wanted to make absolutely sure I clarify those steps. So we're working as hard as we can to get to that point. So what is the idea behind doing this work? When we are cancer patients, we come through the door and we are really all different. But we typically, if we have ALK-driven disease, or if we have breast cancer or gallbladder cancer or colorectal cancer, if we have a certain kind of cancer at a certain stage, we get a certain treatment. Some of us maybe are high drug effect people who do very well with that pill, treatment A. But many of us may not be in that category. When we first come in, we don't know who's who. So what is precision cancer therapy? Precision cancer therapy is to take everyone that comes through and understand the molecular makeup of the host, the tumor, and also the drug sensitivity of the live cells in the patient in as close to a realistic representation of the cancer that is affecting the life of the patient. And that's why we are so keen on understanding live cells, growing them in 3 dimensions, and you'll see a picture in real life soon on the right here, and actually doing these curves that doctors like Dr. Chen can then take eventually and understand. And therefore, we like to be able to suggest that people be sorted into different treatments, hoping that everyone gets a high drug effect, that everyone gets cured or gets their disease controlled. This is the goal of precision therapy. Unless we do this part, we are close but not completely precise. Most patients diagnosed with many cancers today, and ALK for sure, ALK-driven disease, they will have next generation sequencing or some other kind of molecular testing. This is what the tumor may look like from the operating room. We dissociate the cells. We put them in 3-dimensional dishes, so they are not in a flat dish. They are growing a lot similarly to how they are growing in the patient. And this is what they look like. This is the organoid. And we're starting to give this organoid a drug that really will kill the cells, because you see it's starting to have all these other little things, and that's killing the cells. And then here it killed all the cells. The cells are all dead. And that is the curve right here. So we started with 100% of the cells alive, or we are ending up with just 1 or 2% of the cells alive, and we increase the dose, we'll go to 0. So this is the goal of having that happen, and to have a long list of drugs that we can suggest. So now, what do we do next? We already know that many patients are already on treatment, right? Thousands of patients are on treatment. But there is resistance that evolves. So this organoid system allows us to then take a look. If the drugs don't kill all the cells, what are the cells left over like? What do they do? What kind of mutations do they have? Did they get resistance because they were exposed to the drug, or did they have resistance before? The tumor just came with it, and it was a very rare cell that had the resistance. But when we killed all the cells that were sensitive, this rare cell sees the opportunity to consume all the nutrients and expands the clone. We think a lot of that may be going on. It is going on in many other cancers. It hasn't been sufficiently explored in ALK-driven disease. So all these are associated questions that we are trying to answer with each patient material that we looked at. So now I'd like to pass the presentation over to Dr. Peggy Sue, and I already told you she's in charge of Project 2. So Peggy, please.
Thank you, Sophia. It's really nice to meet all of you. Just want to introduce myself. I'm an oncologist scientist, and I trained in oncology at Dana-Farber and Mass General, and moved to Michigan in 2020, where I have been developing my lab, which studies the mechanisms of how normal lung stem cells become cancer cells, and also on the metabolic vulnerabilities of lung cancer. So as an aside, I should mention that I was drawn to studying lung cancer for pretty much 2 reasons. One, I think there's really been an excitement in all the ways that we can treat lung cancer and that have brought benefit to many patients, but it's really clear that there's a lot of work that still remains. And secondarily, and more personally, I should mention that during oncology fellowship, Alice Shaw was my mentor, and I was very much inspired by her. She's a wonderful role model, just a really wonderful doctor, but also passionate about research and improving therapies. So as Sophia mentioned, we as a group are really interested in studying the entire lifespan of the disease, including at the beginning of cancer with its cell of origin. So in the lung, there's an array of cell types which perform various functions, including oxygen uptake, secreting substances that serve as a barrier, defending against infections like COVID. And a few of these cell types are called stem cells, and they're special in that they can proliferate and give rise to other cell types of the lung, either just during normal wear and tear or aging, or under injury or infection. And so shown on this slide is a diagram, it's a cartoon diagram of the cell types of the airways and the alveoli where gas exchange happens. And it's thought that these stem cells are the cells that, when ALK is mutated and activated, become the cell of origin that gives rise to cancer. So in my research, we isolate the lung stem cells from patients. And so shown here on the slide is a picture of some of these stem cells that we grow in my lab. We then activate ALK to understand the earliest changes in cells. And this really includes everything from how the cells might change their identity, how they might rewire their metabolism, and how they could become sensitive to different drugs. So we want to understand how the cancer starts in order to understand how to prevent it from progressing, and also how to understand how we can detect it earlier. So our goal with this system, and Sophie, you can go to the next slide, is not only to understand the early events, but also to tease apart differences that can occur across different ALK variants. And we cross-reference studies from both animal models like mice and material directly from the patient. And we can also culture, using similar techniques, the tumors from the patients and study them as well. And with that, I'll pass it along.
Angel, you want to continue?
Sure. So my name is Angel Chen. I'm a thoracic medical oncologist at the University of Michigan. I did my training at Case Western in Ohio, and then came to Michigan for a fellowship and stayed on here. So I'm a clinician. I see patients in the clinic. It's what I love to do. I love talking to people and getting to know their stories. And then my area of interest from the research perspective is really clinical trials. I think what's really exciting is to be able to bring new treatments that hopefully are better and give patients the opportunity to perhaps have something that can really change the trajectory of their disease. I think what really drew me particularly to lung cancer actually is my mother actually is a breast cancer survivor, so I have personal reasons to want to be an oncologist, but I actually always thought I was going to be a breast oncologist. And I quickly realized, though, that there was so much that needed to be done in the arena of lung cancer. And there were so many exciting things coming out that I changed my mind in fellowship and became a thoracic oncologist and never looked back. I think from my perspective as a clinician, what I see is how much patients go through, from the toxicities of the drugs itself, from the financial toxicities that can occur with the treatments. There's just so much that the patients have to go through. And I'm so grateful that you all do, but I feel like my job is to make sure that that's better. And so what I think my role as part of this amazing team is to take all this smart science that Dr. Mariver, Dr. Sue, and others are doing and really try to bring it into the clinic in a way that, is optimal in terms of treating the disease, but also making sure that we're still preserving that quality of life, which I emphasize so much with my patients, and just really move forward, move ALK forward as best as we can. So I think we can open up to questions.
Yes, thank you.
I got a question for Dr. Mariver, and that is, can you please walk us through, let's say I progress and I go and I get biopsied at University of Michigan. What is the next steps. If you can walk us through, and then we can open up for some questions, just to give an audience an idea of how it works. Is Dr. Maraver still on? Maybe Dr. Sue or Dr. Chen, do you know? Do you have an idea of what it?
Yes,
how to walk us
I can
through?
start. Yep.
All right.
It looks like we may have lost Sophia.
Okay.
So,
So walk us through. I
yeah.
progress. I have to go to university at this point, go to University of Michigan, and I get biopsied. And then what happens to us, to my cancer?
Yeah, so you would be under the care of an oncologist like Dr. Chen, who would be seeing you. And then we would organize it such that your biopsy, we collect fresh cells from that biopsy the day of the procedure. And then that those cells undergo this testing that Dr. Maraver described, where really fresh tumor is plated into cells and exposed to drugs. And the number of drugs that can, and identity of the drugs that can be tested is really dependent on how much tissue there is. So for example, for surgical resections, we can test many conditions. For biopsies, it's limited by the tissue. And then after about a week and a half to 2 weeks, there is some data on drug sensitivity for that tissue. Now, at the moment, it's very much a research protocol. So we get that information and we can share it with your doctor, like Dr. Chen, or potentially your doctor back in your home institution, but it is not yet what we call CLIA certified. Hasn't been tested under a clinical trial yet, but we would at least have that information. And we do intend to share it with patients, but we just need to make sure that we do it in a way that, respects kind of these protocols.
And you mentioned there's roughly anywhere from 20 to 100 different compounds or drugs, from chemotherapies to novel therapies. What happens to the drugs that are in right now in clinical trial for ALK? Would they be considered?
So we're working, and maybe Dr. Chen can say more about that. We're actually trying to work with companies like Nuvalent and Turning Point to have access to their drugs. At the moment, we are only testing approved drugs or combinations in addition to chemotherapy. And so, but our goal is to have access to clinical trial drugs. And that's not something that we'll be able to do immediately, but is our goal. And Dr. Chen can speak more about that.
And I just want to make everyone aware that this is something that's evolving over time. It's not, and Dr. Maraver, you can kind of talk about a little bit of how this came together so quickly, and how it's like warp speed, to find that, that cure, correct?
Yeah, it is a warp speed. Well, to find the cure or to find the best quality of life and control of the disease for each patient, that's the key. How do we get to that point where we are comfortable that we have very, very strong information that the clinicians and the patients can then get together? We are not there yet, but we are working towards that. You have to start somewhere, and we do need access to not just the patient material. It is not a one-time thing. It is patients' trajectories too. So we need a lot of information for understanding whether our predictions are in fact realized. So somebody contributes to the research, we do the experiments, and we have certain predictions. Then the patient is treated with whatever the patient and their doctor decide is the best. But then it would be a fantastic thing to know what happened, what the patient was treated with, how did the patient do, excuse me, and what is the concordance with our predictions. So that is part of engagement in in this research, there will be a longitudinal follow-up piece and of accessing through the patients. We hope we haven't completely fleshed this out. We are about to have a overall program manager on the group, and because it's been me so far, and it is difficult for me to play that function dispatch that function in the best possible way at the same time as doing the research and reading the papers and seeing the patients. But we are going to have probably a lot of online interactions for the patients to provide us with information. All that is yet to be approved at the ethics level. So it is we think for the near to mid future, in the next few months, we'll have all that in place. So rest assured that the participation of the patients is key to the success of this endeavor, and we're very committed to engage safely and to protect your health information, of course, and everything that comes with the incredible honor of working with patient material.
And the patient material, the size of the material, like a needle biopsy wouldn't be good enough. It wouldn't be enough material, correct? Like, give us a general idea of what you're looking for.
Well, not all needles are the same size, and not all organs are amenable to all the same size. So there are some core biopsies that may be sufficient for certain types of, for a smaller panel. I heard a question you asked, Mark, about drugs in clinical trials. Essentially, Dr. Chen, correct me if I'm wrong, but every single drug that Dr. Chen has heard of through her interactions with the lung specialists all around the world when she participates in meetings, all the clinical trials that are on clinicaltrials.gov, all the drugs that are what is called IND for testing in humans, all of them are in our possession at the present time, with maybe one or two exceptions, but there will soon be no exceptions as long as the drug company or the inventors do not mind giving us the drug to test under conditions that obviously will never divulge the structure, and we don't know the structure. They don't tell us.
Plus, you're also working on with your own
yes,
people at University of Michigan to
yes,
develop some new drugs.
Yes, I can tell you a little bit about that. We are very excited about that because this group that has joined the team has been very successful in finding very, very effective inhibitors against other oncogenes that have a lot of similarities to ALK. And one such oncogene is able, and many of you know that BCR and able get together and they also form a fusion that causes cancer. And so that work is now being translated to attack ALK. And we are making a lot of new models to test new drugs in the lab with longer and shorter variants of the ALK fusion. We are essentially going to have models for all the variants known eventually, but right now we are definitely looking at long and short. So we are bringing all those models, and we're developing right now. We're cloning to make sure we get all the right genes in there at the right junctions perfectly. And so all that is going on. These models did not exist before. And so now when we develop them, we'll also make them available broadly. So we are here to help to link with other teams, and ALKpositive.org has been wonderful so far in suggesting teams, and we have accessed them, and we are slowly communicating and gathering with them.
One thing you did not mention is that your physics background, which I think is very fascinating. So, because it gives you a different perspective of what you're trying to accomplish, you know.
Yeah, so my physics background is very helpful to me because it's a language. Math and physics are languages that can be used to dissect any scientific problem, including biology. So up to now, up until very recently, biology was quite dissociated from math and physics. But that's no longer the case, especially in the cancer field. Starting about 20 years ago, it became pretty fashionable to begin to think in mathematical terms. And I still feel that way, that that's a very important part of the rigor of this work, is to understand the physics of it too, because these cells are behaving in different ways than, you might say, well, why didn't we do this before? We've known how to culture cells for 60 or 70 years really well, and probably longer, maybe not so well, but such a long time. What happened? We knew about drugs. We knew some drugs kill cancer, some drugs don't. Why didn't we do that before? Of course we did. But what happened is that work was not correlating with what's happening in animal models or in humans. And the reason for that, one of the many reasons, was that the system was not realistic, was not a realistic representation of what's going on in the patient. So that's what we strive to understand.
Yeah, let's hit some questions here. And like I said, some of them you might not even know the answers to at this point, so you can just say pass. How do you establish if you're going through progression, how do you establish a relationship with University of Michigan?
Well, I think it is very simple. My email is broadly known, and I'm happy to give it. Somebody can write to me or to Dr. Chen, but I'm happy to get the first email, and several people have written already, and I try to answer certainly within a few hours, sometimes within an hour if I can. I consider those emails a great honor and very important. However, what happens afterwards depends on the individual case, so I cannot say for sure. It depends if somebody can come to Michigan or is interested in coming to the University of Michigan because they are close to a decision point in their trajectory. Maybe they're having a side effect or they need to select a new regimen. If that's a good time to maybe seek a second or third opinion in cancer in general, and in ALK disease is no exception. So I will get them with Dr. Chen. We'll review the records, especially the molecular makeup of the tumor, etc., whatever the patient is sharing with us. And then we'd of course like to communicate with the oncologist or the treating provider at the home institution. So there will be different paths for different people. We haven't sorted out all the regulatory steps for having the collection occur remotely for operations or biopsies. That's complicated and will require some sort of approval locally. And so we are sorting that out right now with our two collaborators who are local. One is Dr. Gad Gill at Henry Ford Hospital, and the other one are thoracic oncologists at St. Joseph Mercy Hospital in Ypsilanti. So they are going to be our test cases about how this will work, and then we'll expand it beyond Michigan.
So if you have a patient that's progressing and they start out with the first line TKI and they progressed, and there is a known second TKI for them because they had an NGS testing, would that be a candidate, or would that be someone that would just jump onto the next TKI? I know you're not their doctor, but just overall, if there's an opinion.
Well, I would like to answer, and I would like to pass it to Dr. Chen, who's the lung oncologist. In general, our approvals right now are for obtaining a sample at the time that a sampling is clinically indicated. So that's between the patient and their doctor, whatever institution they're at. So, Dr. Chen, is that what you think is correct?
Yeah, so I think that that's a really great question. I think right now, because we're just in, as we've talked about in the beginning, stages, we right now it's more is research, right? And the hope of the goal of the research is to bring it to the clinic ASAP. So I think that we wouldn't necessarily want to derail your standard of care treatment. So if you're on a first generation or a first ALK TKI and you progress and there's an obvious second choice, I don't think, we should derail plans um and have you change your treatment per se. But I think if at the time of progression, a biopsy is recommended, which it is, and we can discuss the many different forms of biopsies that can be done. And then at that time, you're willing to, consider giving some of that material for us. I think that would be the best scenario in that case. But I think then the other clinical scenarios when we've kind of exhausted our ALK TKIs, right? And now we're facing with, are we looking at clinical trials versus chemotherapy, your kind of generic chemotherapy, then I think it'd be really great and a very important point to then consider participating in this study.
And there was well, to follow up with that question, I guess, is there's a question in the chat in regards to if someone is diagnosed with it initially, would it be more useful for them to know what would really attack the cancer cells versus just jumping onto a alectinib, let's say, or brigatinib?
I mean, I think that's a very a good question. So I think that one of our goals, as Dr. Mariver mentioned, is also to understand the longitudinal course of a patient's journey with ALK. And so, we've been talking about the idea of having like just an ALK registry with University of Michigan, where we would have patients, simply give us some basic clinical information or contact information. That way, we would know of these patients. And so it's not like when they progress, they have to go, oh my gosh, they're scrambling to get in contact with one of us. They would kind of be in the registry, so to speak. But I don't think yet we have enough from our research to know that we have enough to say you should not start alectinib. I think that alectinib is a standard of care for a reason, right? It's a lot of clinical work went into it to establish it. But I think it would be amazing if one day down the road we could even personalize frontline therapy of ALK, but that is some time away.
Follow-up question to that, and that is, if I have G1202R, let's say, and another one has G1202R, and then we have would we have the same resistance, or would it be totally different for different individuals, or like a double combination of two different mutation compounds? Would we have the same drug that would work for us because we have the same mutation, or are we individuals? We don't know.
I think so. My clinical gestalt is that I think we're all different. And I think that, you raise a really great point, right? So right now, a standard of care is if you progress on an ALK TKI, you get a biopsy. And a lot of times those biopsies come in the form of a liquid biopsy through, plasma, testing your blood to see what ALK mutations are still there. We're given an answer report to your oncologist, and you try to make the best of that report in terms of what that means clinically. But to your point, I don't think all G1202Rs are the same because the context of that mutation may be different, right? So what else is going on in your ALK lung cancer versus someone else's lung cancer that perhaps is impacting the development of this G1202R mutation? And then what are the other concurrent ALK mutations that exist? I think those are all very much individualized. And I think that's why you're seeing this different responses, right? Not everybody with G1202R necessarily have the same response to lorlatinib, for example. And I think it's because there's so much else that's going on in a person's body that is different for every individual.
And that's why you're divided to 3 different programs, so you can do the research and also do for the individual patient as an example.
Precisely. If it were all about the mutations, we wouldn't need to do the project. but then we would cure everyone, right? Because we have inhibitors.
That wouldn't be that bad, by the way. But
no, I know, but we have inhibitors to the mutations. You know, in the case of breast cancer, you know, we have amplification of a gene, and we have an antibody that links directly to that molecule. But we don't cure everyone with that amplification, because we learned that the cancers, to become cancer and to be invasive, they have different conduits. Not an infinite number of them, but a large number of ways to overcome the barriers that the body puts up to fight it. Not just from the point of view of immunity, but other cells, how they are supporting the cancer. So that's the work of Project 2, is to really understand all of those mechanisms. And then together with the mutations to really clobber it. So that's the goal.
okay, I think we might have answered some of this, but how much biopsy tissue is enough?
You know, the biopsy tissue, for example, from the operating room, if we can get a centimeter is less than half an inch. An inch is 2.56 centimeters. So it's just less than half an inch of tissue. A lot of people are going to the operating room and have that much tissue, in several times that amount of tissue resected. So most of it is not utilized for clinical care. So this is relatively easy because it's tissue that would otherwise not be used. And so we would like to, you know, prioritize getting as large a piece of tissue as possible, but a centimeter is nice.
And I want to just mention to the people that are on this call, Enigma, which is Justin Gaynor and Jessica Lynn, that's not live tissue. This is live tissue, and that is stored tissue. So there's a difference in this. And I wouldn't call this a study. What would you call this? This isn't a study. What?
It is translational research. It is a clinical translational study. It's what it is. A translational meaning it's from the lab to the clinic. So there is a communication between the lab and the clinic, and between the clinic and the lab. So it is not what we call an interventional study where you get drug A versus drug B. We're gonna get there, and also potentially, if we get to the point of being completely certified to do the analysis that we are doing, eventually we hope to do this analysis in multiple clinical trials that people are developing. If there will be sampling.
And the difference is in this trial, my cells will have my name attached to them somehow, and you're still trying to develop that end of the program.
Right. Yeah. I mean, we want to follow people's trajectories. In order to follow people's trajectories, we need to know who they are, right? And so when you send me an email with your story, you are telling me it's okay for me to know who you are and to know your record and so on. So all of us have different levels of wanting to share our information. But for us, in order to make the most sense out of our predictions, we would like to have a very good trajectory. So the association with patients who are in our cohort of patients that we are studying now and will study in the future, will be long term.
Right. And you mentioned at the very beginning how you're collaborating with a lot of different institutions, and I want people to know that University of Michigan is reaching out to worldwide
Yes.
institutions. So
Yes.
you don't have to all drive to Ann Arbor at once. So
it's very
I do live in
icy
Michigan,
today.
by the way. You can stay at my house, but
it's very icy today. But
yeah,
no,
cold.
we have the best weather. I know everybody wants to come here, but sorry about that. No, it's really wonderful to hear from you and from all of you. So don't hesitate. If all of you write at once, maybe I won't be able to answer within an hour, but I'll try. We're very eager to be part of the community. We are very appreciative of your time and effort. All your advocacy is what makes all the difference. And we'll stay in touch. We anticipate that through ALKpositive.org, and through our collaborators, we'll be able to reach out to a very large number of patients and study their trajectory, study their samples. We are developing novel ways of trying to follow the disease, perhaps with circulating tumor cells. That's all at the research stage, but we're trying that too. We didn't have time to talk about that today. Maybe if you invite us back, we will.
Oh,
When
for
we
sure,
have
we'll
more
invite you
data.
back. We will also, as we post this up, we just got Dr. Mariver's email address again, but we are going to post this on our YouTube channel as we always do. And I really appreciate your time, especially on a Sunday. And I appreciate all the doctors coming in, and I especially appreciate Judith Tam for her generous gift to the University of Michigan. And we will be back for part 2, I'm sure, very, very soon. And like I said, it is a developing project. So there'll be many moving pieces to this. So you guys can take yourselves off the mute and say thank you.
Thank you so much.
Thank you so much.
Thank you.
Thank you.
Everyone.
Thank you.
Thank you.
Good luck
Thank you very much.
Thank you.
to life.
Good
Bye.
Good life.
you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
And thank you, Judith.
Thank you.
Thank you, Judith.
Yeah.
Thank you.
All right. We'll see
Thank
you guys
you.
in a couple weeks. Thank you so much.
Thank you from Michigan. Maybe I'll see you soon.
All right.
Thank you,
Go
Mark.
blue.
Thank
Just
you.
call me.
blue.
Thank you so much.
Thank you, Dr. Major.
Bye. Bye.